Hi, everyone. Thank you for joining us. My name is Omar Abdihamid. I'm a clinical oncologist working in Kenya. I'll be the moderator of this session today. Good. So I'll start with the introduction of our speaker today, Dr. Khalid Al-Bairi. Khalid is a clinical research fellow in academic oncology with a focus on ovarian cancer. He's situated, he works at the Faculty of Medicine of Sciences in the University of Polytechnic in Morocco, Mohammed VI. I get that Roman number right. Khalid is an active researcher with more than 65 peer-reviewed publications, mainly focusing on affordable biomarkers for gynecological cancers, and particularly ovarian cancer in resource-limited setting. He's also an active member of AORTIC, which is our body today that is hosting this webinar. AORTIC stands for African Organization for Research and Training in Cancer, as well as American Society of Clinical Oncology. He's all a member of all those. He's passionate about educating medical and PhD students on evidence-based medicine, clinical research methodologies, and publishing ethics and integrity. Publishing in ethics and integrity. Dr. Bairi will talk to us today about how to critically appraise meta-analysis in randomized clinical trial, and specifically in oncology, with a clinical case discussion. We encourage you to actively participate in the webinar. You can join by, in the Q&A chat box to put your questions, your comments, and suggestions. Dr. Khalid, take it away.
Thank you so much, Omar. It's really a pleasure to have you today moderating this webinar of the Educational and Training Committee of the AORTIC, a great organization with whom I'm currently working to improve education on oncology and other related topics in Africa. So I don't know, do you see my first slide? Do you hear me very well?
Yes, loud and clear.
Okay, great. So today I will be, let's say, summarizing some very important information about the methodological assessment of meta-analysis from randomized controlled trials in oncology. You know that they are considered as a high level of evidence, but unfortunately, with the current landscape of the integrity of clinical trials and meta-analysis, sometimes even if it's qualified as highly as high evidence, but unfortunately it might have some issues and concerns that might really impact your decision making. So I will be discussing today this topic through a clinical case. I think it's the best thing to happen to understand better the impact of meta-analysis in decision making in clinical practice, and also have some takeaways for you in all the fields of oncology, not just on the topic of the clinical case I will be discussing today. And it's also the that the steps to apprise a meta-analysis can be extrapolable to other fields as well. So even if you are not in oncology, you may use the same reasoning for your cases in your daily practice. So before I start my presentations, I would like to declare my conflict of interests. I don't know why my slides are not going on. Just give me one.
Yeah, Khalid, your slides are not moving.
Yeah, one moment, please. Yeah, I think now you are seeing my slides, right?
Yes.
Great. So these are my conflict of interests. It's very important to declare them before I start my presentations. In some slides, I declare my opinions, which are my own, and they do not reflect really the vision of the AORTIC or my affiliation where I am currently working. I do not interact with pharmaceutical industry, and I will not interact with them because I do a lot of research in the field of integrity. So, a researcher in that field should really limit his interactions with pharma. So these are my disclosures, and they are already published online at the website of ASCO. So this is our case. I would like to discuss with you today. It's very simple. It's a case of a patient that you may see in your daily practice of oncology. It's a woman aged 44 years old. She is currently taking non-steroids for her rheumatoid arthritis. She presented at your clinic with chronic abdominal pain, with pelvic pain as well. So she has family history of breast cancer, first degree relative. So in this case, when you receive such a patient, of course, the first thing to think about is to do an ultrasound. So an ultrasound combined with CT scan were requested, and it finds two bilateral hyperechogenic ovarian masses with dense vascularization, and also peritoneal deposits and acids were seen on CT scan, and also there were involvement of the spleen and small bowel as secondary metastasis. So, of course, to orient more, if it's really an ovarian cancer or not, you might ask CA125, and it's highly positive here. And in this case, you will request your surgeon to do laparoscopy biopsy to confirm the ovarian cancer through biopsy, and also to do better FIGO staging. And the patient was also BRCA mutated, as you can see here. After doing the pathological assessment, it was high-grade serous ovarian carcinoma, typically advanced ovarian cancer with FIGO stage 3C in staging. So the patient in this case may receive two therapeutic approaches, as you know. We might start with doing surgery first and then followed by chemotherapy, or you can do neoadjuvant chemotherapy and then followed by debulking. So both approaches have high level of evidence according to randomized controlled trials. And we would like to know, if you start by neoadjuvant chemotherapy, are we going to have any beneficial impact for our patient? So our question is, if we do neoadjuvant chemotherapy first, what are the potential benefits in terms of patient outcomes and post-operative complications? Is it going to help the surgeon to be more doing R0, do optimal debulking or not? And also in terms of progression-free survival and overall survival, are we going to gain anything if we start first by neoadjuvant chemotherapy? So the second part of the clinical case, the second question I need to answer today through this presentation. So our patient developed neutropenia and anemia after chemotherapy. It's something frequent you may see in this case. So following debulking surgery, she developed a surgical site infection with deep vein thrombosis and pain. The medical and nursing team met to design an evidence-based intervention to see if we can prevent this to happen in the future. So you know that our decision making in the clinic should be inclusive, and we always take the opinion of nurses, oncology nurses, because they might help in this case. So a nurse proposed the rapid rehabilitation nursing model for all patients undergoing surgery to help preventing venous thrombosis and pain, as well as surgical site infection. So the question we always ask, is there evidence to support this therapeutic approach? The second part of the clinical case is very, very important in terms of the integrity of meta-analysis. So during the tumor board, which recommended to continue on non-steroids using celecoxib for this patient for her osteoarthritis. Do not forget that this is one of her comorbidities. So a resident raised the concern about the heavy influence of pharmaceutical industry on the design and reporting of randomized controlled trials in this setting. We would like to know that if there is a way to know if pharma influenced the reporting and the design of the randomized controlled trials included in meta-analysis. If yes, is there a place to find this answer? So our third question I need to answer today is, how can you know that a randomized controlled trial might be biased by pharmaceutical industry influence? So the first thing you need to do when you need to answer these kind of questions is to develop your PICO. So the PICO, as you know, is very important to find the clinical question, also the keywords to be used for PubMed and other databases. So our population is advanced ovarian cancer. It's FIGO stage 3C, as you know. The intervention we need to demonstrate as effective is neoadjuvant chemotherapy, and our comparator is debulking surgery. So we need to evaluate the impact of neoadjuvant chemotherapy on the patient outcomes. So here the outcomes may be overall survival, progression-free survival, debulking rates, post or peri-operative events, quality of life. So all what you can expect in terms of outcome. So our first question is, in patients with advanced ovarian cancer, stage 3 or more, does NACT, neoadjuvant chemotherapy, compared with primary debulking surgery, improve overall survival, progression-free survival, and the Polkin rates. So of course, as a young oncologist, the first thing to think about to find evidence for your clinical decision is PubMed. So in PubMed, the best thing to do, instead of doing just standard keywords, you need to go to the MASH database, because it allows you to find more papers using the medical search hidden terms. So what we do here when using PubMed is to find the best mesh for your keywords. Here, for example, you put ovarian cancer, and you find a lot of meshes that may define better your keyword, because the more you have the accurate mesh, the more the probability to find all the studies exhaustively that we're trying to answer the question. So here we found ovarian neoplasm, which is a mesh that includes a lot of C9, including ovarian tumors, ovarian neoplasms, in ovarian malignancies, etc. So this is our first criterion. The second criterion, we need to answer our question, of course. So we need the second keyword. So here we use neoadjuvant therapy. It's already a mesh on PubMed. So you need just to add it to your combination here on PubMed. And then, of course, once you click on enter search, you will find a lot of studies. Here, it's more than 600 studies that try to answer having the combined terms. So, of course, this is a lot of papers. You cannot read all of them. The second part is that you need, of course, to find only recent studies. So on the filters you have on PubMed, you can select 5 years, the latest evidence published in the last 5 years. So here we reduce the number of publications to 300. But 300 is also a lot of studies, so you cannot read all of them. Of course, you need a second filter, and of course, in this case, and based on your understanding of evidence-based medicine, the best types of articles you need to read first is meta-analysis and systematic reviews of randomized controlled trials, and it's a filter already available on PubMed. So you select it here, you click on show, and then you will find only, as mentioned here, 5 meta-analysis or less. So here, another criterion maybe use it to find which is really the best paper for you. It can be the year of publication, the latest one, for example. It can be the journal where it is published. So for me, as let's say a young oncologist as a resident, I will select one of them, published in a good journal, and also published in the latest year, for example. Or even you can use the authors who published studies, if they're experts or not. But for here, all what we want from this filtering here is to find less papers. So 5 meta-analysis, I think it's enough to answer our clinical question. So I selected randomly one of them here. So this is the paper we are going to discuss first. It's a meta-analysis that really answered our question. So they also to systematically in surgery in patients with advanced epithelial ovarian cancer, starting from FIGO stage 3C or more. So the first thing to find in meta-analysis is called the systematic review. And in a systematic review, do you still hear me well?
Yes, Khalid, we can hear you.
Good, good. Just my internet is unstable, so I just need to know that you are really hearing me very well. So this is the way the authors found those randomized controlled trials that are going to be meta-analyzed to do the polling analysis at the end to find evidence for our clinical question. So in systematic review, there are 4 steps to be conducted to find by authors. It's
Khalid, are you there? I think we lost you for a second. Khalid, we can't hear you.
Do you hear me now?
Yeah, you lost you for a minute, but I think I can hear you now.
Okay, great. So yeah, I was telling here that there are four steps that are very important when doing systematic review before pulling the data for the meta-analysis. Is called the systematic review. So it's four steps that are required. I want just to share a very important takeaway from the screening to the eligibility to the inclusion. So here sometimes if it's pharmaceutical industry sponsored systematic review, there may be some negative studies that are excluded. So you need to be careful because sometimes when you meta-analyze positive studies, you will find a positive meta-analysis. So in this case here, for example, the authors they excluded conference abstracts. So basically, conference abstract they have also very important data. They are those trials that are communicated in international conferences like the annual meeting of ASCO or ISMO. So when the meta-analysis is sponsored by a pharmaceutical industry or when the authors have conflict of interest with industry, sometimes they exclude negative studies to meta-analyze only positive studies. Of course, when you meta-analyze positive studies, you will always find a positive conclusion. So here, when you find a systematic review with exclusion of negative studies, be very careful. It's not really a good idea in terms of ethics and integrity of meta-analysis. So the second thing you need to find in meta-analysis, it's very important for critical appraisal. It's called the risk of bias tool because one of the other reasons we do meta-analysis is not just to combine the data from randomized controlled trials, but also to find objectively if there is any risk of bias in included studies. So this is called risk of bias tool. It's something developed by Cochrane. I will talk about Cochrane later in my presentation. It's a way to see if randomized controlled trials included in a meta-analysis are respecting some of the very important criteria for a good clinical trial. For example, we have a lot of criteria here. We have random sequence generation. We have allocation concealment. Allocation concealment, for example, is a type of bias when, for example, some investigators already know the next patients to be included in the study when doing randomization. The random sequence generation is also very important because in randomized controlled trials, both in intervention and in the control, patients should have the same chance to be treated with one of the two arms. If there is inequalities in being treated with one of the interventions, this might create some bias as well. Blinding is also very important in randomized controlled trials. So this is called performance bias. It should be really reported in details in randomized controlled trials. The blinding of the outcomes assessment, it's called detection bias. It's very important because you need to assess the response to treatment objectively. So the authors should be very careful when reporting information about blinding the outcome. Sometimes you have randomized controlled trials with problem in follow-up. So the follow-up is not really optimal. So you might have incomplete data about survival, and this is not really a good idea when reporting randomized controlled trial. And it's called attrition bias, as you know. When you write the report of randomized controlled trial, you need really to follow the consort guidelines checklist to not have reporting bias. So all of this information about bias can be seen in meta-analysis. And when everything looks okay, everything looks great in the included studies, here it's green color. When the information is not really reported accurately by the investigators, the color is yellow. And when the information is not available, which means that there is really the bias is there present, it's red. So here, this is a general assessment of all randomized controlled trials included in the meta-analysis we are discussing now. So here, it looks good because there is only one study by Rose included in meta-analysis that might have some underreporting of the information related to random sequence generation and allocation concealment. So if you have this problem in this study, this might influence the bias in the studies, and it might influence the final conclusions of the meta-analysis. There may be some solution to this later. We can do subgroup analysis to see if this study really influenced the outcome or not. But for instance, this is not a good idea. This is not a good study in terms of these two type of bias. For blinding of participants and personnel, it does make sense to have it red here just because it's surgery trials. So you cannot really do blinding of personnel of the investigators when doing surgery. So here it's okay to have red color when it's a surgical clinical trial. So the third thing to find in a meta-analysis is called the forest plot. It's very, very, very important because basically oncologists always go to the overall effect to see if the treatment is beneficial or not compared to a placebo or compared to a control. But this is not really the only thing to read in a forest plot. So what I recommend is that you need to read all the details. So I will be just describing a little bit for those who are not really familiar with forest plots. So in a forest plot, you have on the left, you have all studies included, study A, B, and C. These are randomized controlled trials. You have the intervention group with its sample size and the events. So for every for every randomized controlled trials, you may see events related to mortality or progressions, for example, recurrence, etc. So the number of events and then the total number of patients included in the intervention, and also the same for the control because it's randomized control trial. So you need to have also the same thing for the control group. Also, on the forest plots, in addition to the studies included here, you might find their weight compared to the whole meta-analysis, which means according to the sample size of each study, how this weight in terms of percentage of the whole population included, and then of course to evaluate the efficacy in randomized controlled trials in oncology, you need hazard ratio. If it's not a study having survival data, which means time to event data, you might have other things like in control studies, you might find odds ratios, etc., relative risks, etc., in cohorts. But in randomized control trials, always here it's a hazard ratio. So you have hazard ratios here described for each study, and then you have their confidence interval, which is very, very important. And then all of this data that are numerical, they are just explained using the graph. So these rectangles here, they are just the hazard ratios described here numerically, and the line that is horizontal here, it's just the confidence interval. And of course, you have a reference line here starting from 0 to more than 1. So when you know that when it's more than 1, it favors the control. When it's less than 1, it favors your intervention. And be careful here because it depends on the direction of the hypothesis you are testing in the randomized control trial. But in standard randomized control trials, when it's more than 1, it's favoring the control. It can be a placebo or something else. And in some other cases, when it's less than 1, it favors the intervention. So this is just a description of the numerical data we have in studies here, okay? And basically, you have a line of no effect. It's 1. So when the confidence interval touches the line, it means that the difference is not significant. You have a lot of studies here. There are 3, okay? Some of them, like here, studies C, for example, it favors the control. The other ones, they favor the intervention, but the confidence interval touches the line, which means that it's not really significant. So in this case, there is a need to do meta-analysis. So meta-analysis, statistically talking, is just the pooled analysis of all of these studies together. It's called the overall effect, and you will find it here by a losange. So this, if you can see, it's sample size. It's the whole sample size of all studies included in the controls and the intervention. And then again, when it touches a line, it means that there is no difference between the control and the intervention. When it is more on the left, it favors the intervention. When it's on the right, it favors the control. So this is called the overall effect. You can interpret it easily as I describe it, but be careful. This is not enough. You need always to have information about the heterogeneity. Sometimes you have population heterogeneity. There is heterogeneity in terms of comorbidities, in terms of the ethnicity, for example, in terms of the treatments done, in terms of the expertise of the surgeon, in terms of the cycles of the chemotherapy. So there may be a lot of factors that may influence heterogeneity. And of course, when it equals 0, it means that there is no heterogeneity at all. When so I will discuss later what are the cutoffs of the heterogeneity. So for instance, 0% means that there is no heterogeneity. So you can take into consideration the conclusion objectively, which is good. But when there is high heterogeneity, this overall effect, even it favors the intervention, you should not take it into consideration because it may be biased by the heterogeneity. So you need to do other things to see if there is any factors that may explain that, so including subgroup analysis, etc. There is also the methodological heterogeneity. It's related to the design of studies, the way statistical analysis is conducted, etc. So it's not something I will be discussing in this slide. So remember, this is a forest plot. It's easy to understand, but always be careful. You need to discuss it with its heterogeneity. So this is the meta-analysis I took from the study, the meta-analysis I described. So here, the first thing to do is to see if neoadjuvant chemotherapy favors the patients compared to the surgery in terms of overall survival. So here we have 4 studies included in the meta-analysis. We have their hazard ratios. Here is represented as logarithm. And then you have the total number of patients in the neoadjuvant group, and then total patient in the primary debulking surgery group, and then the weight. The weight is just the percentage of each study compared to the whole studies. And of course, you have the confidence intervals, their hazard ratios, and they are just represented graphically here using the forest plot. So here we have some studies. We have one study favoring the neoadjuvant chemotherapy. The others, they touch the line, so there is no difference between the others, between the surgery and the NACT group. So in this case, you need the meta-analysis to be done. So the meta-analysis is represented here by this losange. So you want to understand it better. It has the population for all studies combined together for the neoadjuvant chemotherapy group, and then for the control group, you have the information about the sample size here. So why we have 900? It's just the combination of all the study samples of these studies. So you know that the definition of meta-analysis is just a pooling, okay? So pooling, increasing sample size, and pooling the effect size for each study using statistical methods that will be discussed later. So here, for example, we can say, because the losange touches the line, there is no difference between primary debulking surgery and neoadjuvant chemotherapy in terms of overall survival. So this means that if you start by neoadjuvant chemotherapy or you do surgery first, you will not gain anything in terms of overall survival. So, but unfortunately, well, this is the conclusion, but you need to consider this carefully, because here there is high heterogeneity. The E-square, which is a statistical parameter developed by Cochrane, it gives you a percentage. So when it's more than 50%, it's moderate. Heterogeneity. So you might take the consideration, the conclusion into consideration, but the heterogeneity still exists. So there should be a subgroup analysis to understand better if there is a subgroup of patients that may benefit from the neoadjuvant chemotherapy in terms of overall survival. So the first conclusion, you start with chemotherapy or you do surgery, you will not gain anything in terms of overall survival according to this meta-analysis. In terms of progression-free survival, the losange again of the all studies together included touches the line, and you have here the numerical value of 1 in confidence interval, which means there is no statistically significant result. You can see this directly here from the confidence interval, or you can also have the conclusion from the test of overall effect here of this p-value that is not significant. So here there is no difference again in terms of progression-free survival when you start doing NACT or surgery in this for this clinical case. However, for debulking rates, and I think the forest plot is very important, very interesting. So again, here we just did a meta-analysis to see if the neoadjuvant chemotherapy impacts residual disease, if it impacts the success of the surgery. So here we have 3 important parameters. The no residual disease are 0. So here, when you do neoadjuvant chemotherapy, it favors the neoadjuvant chemotherapy intervention, which means that when you start doing neoadjuvant chemotherapy, biologically, you may reduce the size of the tumors. And then when the surgeon operates, he may remove as much as possible of the bulky tumors, because now they are debulkable. So the impact of neoadjuvant chemotherapy here is very important for the surgeon. He may do R0 easily if he starts with neoadjuvant chemotherapy compared to doing first cytoreduction. And the heterogeneity is 0, which means that this is a conclusion that is valid. You need to consider it when taking your when you want to make a decision for your patient. In terms of suboptimal debulking, so for residual disease less than 1 centimeter, again, the meta-analysis is positive. There is no heterogeneity. The hazard ratio is 1.28, which means that you are doing more CTO reduction compared to the surgery group, which is good for the surgeon as well and also for the patient. And in terms of optimal CTO reduction rate, same conclusions. There is no heterogeneity, and it favors the NACT intervention. So here, according to this meta-analysis, there is no gain in terms of overall survival, no gain in terms of progression-free survival, but in terms of debulking rates, in terms of the success of the surgery, it really impacts significantly the work of the surgeon and without any heterogeneity. So this is really a good point for surgeons, because always we have this difficult decision-making situations in which the surgeon would like to start, and then the oncologist like, let's do neoadjuvant chemotherapy first. But here it's clearly demonstrating that doing neoadjuvant chemotherapy first will help the surgeon to be more effective in delivering surgery for the patient. So in summary, in addition to the pooled analysis, you might get easily from the meta-analysis here by combining the hazard ratios using statistical methods I will describe later. You need always to be careful about the other parameters to be discussed, like the test for heterogeneity. So there is one very valid statistical parameter called the I-square. So the I-square is developed by Cochrane, and it tells you if there is heterogeneity. If yes, can we quantify it? So it's between 0 and 100%. So between 0 and 25, we can say there is low heterogeneity. So you can take the conclusion into consideration and make your decision. When it's around 50%, it's moderate. You need to find from where this heterogeneity came from. When it's high, it's very dangerous to make a decision. So this means that you need to do other things to see if the conclusion is still valid or not. And basically, you can do it by subgroup analysis, sensitivity analysis, etc. So I will discuss this later. So one important thing. So when doing a meta-analysis, there are two models you may use. The authors may use when combining the data from randomized control trials. So there is the fixed effect model. So it's statistical method used by the software when there is no heterogeneity. So it assumes that there is no heterogeneity between studies because it's already quantified by the I-square, and it tells you that really this is a conclusion that is solid, it's valid. But when there is high heterogeneity or moderate heterogeneity, you might ask the software to do the meta-analysis again, but this time using a random effect model, using Mantel-Haenszel method, which is a method that allows to do a better prediction of hazard ratios when there is a high heterogeneity. So this is something you can do using the software of Cochrane. It's called Rivman, and there are also other tools you may use to see which model you can use in your meta-analysis if you are doing it. But the most important conclusion here is that when you have moderate or high heterogeneity, always consider doing subgroup analysis. So in studies in which there is moderate heterogeneity, you should not consider the pooled effect as final, but you need to see the result of doing subgroup analysis and also doing sensitivity analysis. So sensitivity analysis is very simple as a concept. You need just to include studies one by one and see which one increases heterogeneity. Once you know which one, you may exclude it and then do the meta-analysis again and see if the conclusion will still valid or not. You can also do meta-regression. It's an advanced statistical method. It's like doing a randomization again using the data you have, and then it can give you a better assessment of heterogeneity in the meta-analysis. One last important, very, very important step when apprising meta-analysis, in addition to heterogeneity, etc., is called the evaluation of publication bias. If you remember in systematic review, in the diagram of Prisma diagram, I explained that sometimes you have meta-analysis and systematic reviews that excludes negative studies. Because again, when you combine positive studies, you might find a pooled effect that is also positive, which means you are favoring positive studies. And basically, when it's sponsored, when authors have conflict of interest with pharmaceutical industry, you might see this kind of things. But is there a way to know that we are missing studies in the meta-analysis? And this is very important because you want to make objective decision in your clinic. You should not really be biased in your decision. So at least the meta-analysis should not exclude those negative studies. So how can you know that? There is a lot of ways. One of the ways that are recommended by Cochrane Initiative is called the funnel plot. So the funnel plot is a way just to tell you that there are some studies that are missing. So for example, this is typically a symmetrical funnel plot. So all those points you see here, they are just standard error of the mean in the studies, for example. So for each small study, it should have another comparator, another comparative study that is positive. So for all those positive studies, you might have negative studies that are missing, which means that the points are absent. You are not seeing them here in the plot. So this means that, and of course to explain it, just it depends on the sample size. The accurate the sample size, the accuracy of the conclusion you have. But sometimes you have small study effects. So small study effects, it's those studies that are not mature yet. They are excluded from publications. They are not published in journals. They are just communicated as conference abstracts. So you might not see them in the meta-analysis because they are excluded. But here, if you want to know if they are excluded or not, the meta-analysis provides you a funnel plot here on the right. So when you see that there are studies on the left, they should be the equivalent on the right. But here they are absent, which means that there is publication bias, which means that there are studies that should appear here, but they are not. They are excluded by the authors, voluntarily or not, we don't know. But a good meta-analysis should have all studies included. And of course, this is like ultrasound, it's manipulator dependent, it's observer dependent. So we need something more objective. So the Eggers test is here, is something you can see in meta-analysis. It's estimated when you have at least 10 studies in meta-analysis. So when it's significant, it means that there is publication bias. So again, talking about the funnel plots, because in the meta-analysis we are discussing now, there are fewer than 10 studies. So the authors didn't assess publication bias. For sensitivity analysis, they did sensitivity analysis to see if there is a study that have something irregular in the design, in the reporting, in the study population, etc. So they did a sensitivity analysis, and they found that the study by Vanderberg et al., which is a randomized control type 2, likely contributed to the heterogeneity. After excluding this study, they found that it affected overall survival. It didn't affect overall survival, which means that even if you exclude it, there is no difference in terms of overall survival. Why this study affected heterogeneity? If you read the details from this capture of the study, we see that this study included patients who have very, very big bulky tumors. So for this reason, this parameter impacted the survival of patients, and it's something that you can conclude when doing sensitivity analysis of studies to be included in the systematic review and the meta-analysis. So for now, all you should remember: do not consider pooled study effects as final conclusion. Always check heterogeneity. If there is heterogeneity, did the author did any efforts to do subgroup analysis? Did any effort to do sensitivity analysis to know if the studies included having high heterogeneity impacted conclusion or not? This is not enough. You need always to see if there is publication bias. And of course, publication bias can be done using the funnel plot or the Eggers test. And then when there is publication bias, this means that there are studies that are negative, they are excluded, and it's not a good idea because they may impact the conclusion of the meta-analysis. So be careful about these three parameters. When you follow the steps, everything will be okay. So for our patients, neoadjuvant chemotherapy is beneficial for only the surgeon, which means it helps the surgeon to be more optimally delivering surgeries for this patient. So in terms of overall survival, progression-free survival, there is no difference. And it's something you may see in guidelines to date. So as you remember, the patient after surgery developed site infection, thrombosis, and pain. It's something you might frequently see in this kind of patient having surgery because it's heavy surgery. So the nurse who is in your multidisciplinary team board proposed to do a rapid rehabilitation nursing model for all patients undergoing surgery to see if this can prevent site infection to happen and also to reduce the risk of pain, and also to reduce the risk of thrombosis. But the question always, is there evidence to support these statements? So same thing, PICO, advanced ovarian cancer, the intervention is the rapid habilitation nursing model, the comparator, all other approaches, including painkillers, all the approaches you may do for this kind of patient. And you want to know if the outcomes may differ between the intervention and the comparator, and if the rapid rehabilitation nursing might be beneficial better than all other approaches. Same reasoning, PubMed, merge terms, select the best term to include all the keywords possible, so you can have an exhaustive list of meta-analysis possible. The same thing, so you might find a lot of studies. You need always to use filters. You need to read a meta-analysis because it's according to the evidence-based diagram, even if it has a lot of limitations as well. It's the best thing to happen, but it's not really something we consider as final conclusion, because even meta-analysis from randomized controlled trials have limitation problems as well. So this is the meta-analysis, the recent one we found that tried to answer this question. So it studied the effects of rapid rehabilitation nursing model on surgical site wound infection and pain of patients with ovarian cancer. Sorry. So this is a preliminary review of reading the abstract before you go to the details. So the meta-analysis aimed to explore the effect of rapid rehabilitation model on surgical site wound infection and pain with ovarian cancer by combining a lot of randomized control trials together. So the study included 22 articles. It included more than 900 patients, which is good in terms of cancer, of sample size. And let's explore. So this is the diagram of the systematic review. Again, there is no details about excluding conference abstracts, those negative studies, which is not a good idea. This is not better reporting. So be careful about this kind of diagrams. So at the end, they meta-analyzed 22 studies. It's good in terms of sample size, but when the reporting of records excluded is not optimal, you need to be careful about this kind of meta-analysis. So this is the risk of bias, as I explained before. There are some problems related to the allocation concealment. There are some problems related to the blinding of the participants, problems also related to blinding of the outcomes. So this meta-analysis have randomized controlled trials that are not really that trustworthy. So when you see this diagram with a lot of yellow color for this bias type of biases, be careful about its conclusion. This is the first forest plot about the effect of this model on post-operative complications. So here, the risk reduction of post-operative complication is around 70% for this model, which is good. It's really great. So after meta-analyzing all of these studies, 22 studies, the conclusion here through the pooled effect says that it favors the experimental, it favors the arm, which is the rehabilitation model, and there is a risk reduction by 70%, which is great. It's significant because it doesn't touch the line of no effect. You can see here also it's very, very significant. And also in terms of heterogeneity is very, very, very low, which is a conclusion that you might consider in your decision making. Same thing for the wound infection. There is a reduction of the wound infection by 70%, as translated here by this hazard ratio, by the odds ratio, which is good. There is no heterogeneity at all, and this is also a conclusion you might take for your decision making for this patient. In terms of the pain, there is also a reduction. There is an improvement, of management of pain for this patient compared to the other approaches. And there is a high heterogeneity, 99%, 95%. So this means that you should not consider this meta-analysis as final conclusion, and you need to see the subgroup analysis. Unfortunately, the authors did not provide subgroup analysis and did not do sensitivity analysis, and it's really something bad. So you should not consider this conclusion as final for your patient. Again, when you check the publication bias through the funnel plot, if you remember, the authors did not really provide information about excluded studies, why and which type of studies they were excluded, if they exclude conference abstracts. Here you can see from the first funnel plot that there are studies missing here on the right. There are a lot of studies that are positive, but their equivalent are absent, which means that the authors, they didn't do very well in terms of finding articles that might have a big picture about the topic. Final slides. Sorry, it takes longer than expected just because it's a lot of things to share, just a summary, and hopefully we can continue discussing this in questions. Part of this webinar. So first question by the resident is, if you have randomized controlled trials in a meta-analysis and you are afraid that this may have some bias, some influence by pharmaceutical industry, is there a way to know that or not? So what I'm going to discuss with you is something called Cochrane library. It's very, very, very important database for your practice. It's better than PubMed, so I always use it first before going to PubMed. So we want to know if the meta-analysis we are reading have any influence from industry. So the question we want to answer, if the studies conducted on celecoxib for our patient who suffered also from rheumatoid arthritis is influenced by pharmaceutical industry. So Cochrane systematic reviews and meta-analysis, they give you the answer. They objectively assess this parameter as well. So always use it before going to PubMed. It has more details than the standard meta-analysis we read together, and it gives you more information about conflicts of interest of investigators in the meta-analysis you are reading. So this is what I did. I looked into the Cochrane. It's the same way as PubMed in terms of how to find articles, etc. So here it gives you a chapter about all the details about studies included, and if also there is any influence from pharmaceutical industry on the randomized controlled trials included in the meta-analysis. So here you may see from this capture that there are authors who are investigators, authors in the randomized controlled trials who work for pharma. It's different. It's not investigators who conduct studies. It's directly people who work in the pharmaceutical industry. So they are authors in those randomized controlled trials, which is not ethical. It doesn't make sense to have people in pharmaceutical industry area being authors in the randomized control trials that are being conducted by this pharma. If we know that conflict of interest exists between investigator and pharma, but having people working with pharma inside the article, inside the randomized control trial as authors, it's not something ethical. So here, this randomized control, this meta-analysis from Cochrane, it tells you that be careful. There are authors among the investigators who work with pharma. So they influence directly how the outcomes are reported, how they are assessed, and you have all the details here. I don't have time to discuss all these details, but what I can give you as a takeaway, always consider Cochrane if you want to have objective systematic reviews and meta-analysis to be used for daily practice. This is, as you know, the diagram of evidence-based medicine. Systematic reviews and meta-analysis are considered as a high level of evidence, but unfortunately, this is not true currently. Even if they are considered as level of evidence, there may be a lot of problems in terms of heterogeneity, in terms of how we assess heterogeneity, how we report it, how we resolve it, publication bias, a lot of issues. So do not consider randomized controlled trials and their meta-analysis as final conclusion, as good evidence for your daily practice, because they may have limitations and bias as well. And always read carefully what you are reading to take care of a patient in your daily clinic. Thank you so much, and I am really sorry for taking much time for that. It's just a summary, believe me. The field is very big, and I hope to have questions so we can give more details about the topic. Thank you so much.
Thank you, Khalid. That was excellent. And just to confirm that it was very exciting, we did not see a lot of people jumping out of the call, despite it getting a bit repetitive.
Okay.
Long, so that's good. So we only have 5 minutes to the top of the hour, and maybe we can add 3 more minutes after that if possible. There are no many questions, so I'll go directly to the Q&A chat box before I ask some of my questions. So someone is saying, does the selection of papers from high impact factor journal count as a bias in the inclusion of the meta-analysis? I think this is an excellent question. Khalid, do you want to take a stab at that?
Sorry, I couldn't hear you.
Yeah, does the inclusion of high impact
Couldn't
journals?
hear you.
I'm saying that, okay, are you able to see the question? The one that talks about the inclusion of high impact journals,
Okay, sorry, I will see the chat now.
yeah, as a form of bias in the meta-analysis, selecting studies specifically from high impact journal. Does that translate to a bias in the inclusion of the overall meta-analysis of the studies? I think that's a very good question.
Of course, of course. This is very, very important question because we know that pharmaceutical industry sponsored randomized controlled trials they are always published in those highly impact journals, including Lancet, New England Journal of Medicine, etc. So yes, because of the conflict of interest, if you include only those studies from big journals, you may miss some good studies that are published in less impacted journals. So it's not a good idea to include only those mega journals. You need all to be objective, so you need to include all what you found that responds to the inclusion criteria. And if you have a study in a minor journal, but it has really a good scientific question, better reporting, it has the inclusion criteria of your systematic review, yes, of course, you need to include it. And if you include only those studies published in big journals, of course, it will create a lot of bias.
Thank you, Khalid. I agree with you. I think meta-analysis is garbage in, garbage out. Whatever you really put in should really reflect on good. Ahmed Abbasi has a suggestion or a question, and he's suggesting that critical appraisal should be in the weekly teachings of academic centers. I think that's true. We agree with that. I don't see any. Can you? Okay. Can you summarize forest plot? I think you've done that already. Any more questions? I don't see any more questions. Please
Yeah, there
type.
is there is a comment I think from Dr. Rafia. She said that meta-analysis of neoadjuvant chemotherapy in ovarian cancer is old. Yes, I agree. I used it just for educational purposes. It's not really to find the answer if NACT is better or not. So this wasn't really my objective. I took one just as for educational purposes. But of course, you will find a lot of recent meta-analysis on this topic, and I think to date we don't have yet a randomized controlled trial that showed clear superiority of neoadjuvant chemotherapy versus surgery, vice versa. But you will find a lot of recent meta-analysis to be considered for your daily practice.
Great. Please type your questions. We have 3 more minutes to go. Khalid, while people are thinking about their questions, I have one question for you. In a scenario where an existing meta-analysis, let me rephrase that. If a new randomized clinical trial has a newer evidence, but the evidence that was being used before was pulled from meta-analysis, what happens?
Okay, I think from a common sense oncology perspective, it's better to apprise the randomized controlled trials in terms of the quality of study design. If it's really well conducted, we might use it in making a decision for patient. For meta-analyses that are old to date about this topic, they are not really that good enough. So there are a lot of currently ongoing phase 3 trials for NACT in ovarian cancer. If you check their design, they have a lot of flaws, unfortunately. So what I can say is always apprise objectively the study design, the reporting of the finding, and then if there is an RCT that is better than all those previous RCTs included in meta-analysis, I think it's better to consider it as standard.
Good. I see a question here, but I don't know if it's reflected. It came through a private. So someone is asking, what is the difference between systematic review and meta-analysis? This is a good question.
Okay. So a meta-analysis is a systematic review, but not all systematic reviews are meta-analysis. So when you do the quality assessment of included studies in meta-analysis, it's called a systematic review. So you review systematically all the studies responding to inclusion criteria, and then you check their quality using risk of bias tool, this as I described. And then once there is a chance to combine their results, because not always you combine the results, because if there is high heterogeneity and you cannot combine, you do subgroup analysis but heterogeneity is still high, it's better not to do meta-analysis. So the meta-analysis is the last stage in which you combine the results of all the randomized controls trial together. So in one sentence, a systematic review is quality assessment. The meta-analysis is more quantitative assessment to combine the study effects using statistical parameters.
Well done. Okay. All right. I don't see any more question. Maybe can I ask, and Khalid, you see the role of AI in research is coming every day. Do you see any role of AI in meta-analysis in the future?
To the best of my knowledge, I saw some good papers coming from Cochrane Initiative that recommend using some AI tools that are validated from them to do the systematic search, to extract data, etc. So it might help in reducing, the time to do all those time-consuming steps of the systematic review. But to date, there is no clear answer if it's really effective or not. But they are being recommended by Cochrane, for instance.
Okay, thank you. All right, I don't see any more questions. Any final word before we wind up? I think we've gone 2 minutes past the hour. Khalid, can you hear me?
Yes, sorry?
Yeah, any final word before we wind
Yeah.
up?
So we all, as medical doctors, believe in the diagram of evidence-based medicine. We consider randomized controlled trials and their meta-analysis as a high level of evidence, but we need to be very careful because of the industrial influence, because of the low quality of the studies being conducted. So be careful about the conclusion. Always use the CSO principles published in the Lancet if you want to have more good critical appraisal of those studies, and do not consider the conclusions of randomized controlled trials and meta-analysis as final. Always look into the details, because as you know, the devil is in the details.
Thank you, Khalid. Thank you, audience, for joining us. I think that was a very excellent overview of what meta-analysis is. Please join us. Is it next week or next week part one? We'll also be talking
I think
clinical
it's the last week of this month. My colleague Dr. Omaro is moderating today, so I will be moderating your session soon, and we will be discussing another very, very important topic: how to critically appraise randomized controlled trials according, I believe, the CSO principles and other criteria. So please do not forget to join. We will share the flyer and also the invitation on social networks, on LinkedIn, using also the AORTIC page. If you are not AORTIC members, try to join the AORTIC. It's our ASCO. It's doing great for Africa in terms of oncology and training. So try to join, and can't wait to see you soon.
All right. Thank you all. Bye-bye. Have a good one.